Good morning, everyone. I'm Yunyao, oncologist from China. It is a great honor to take part in the International Breast Cancer Conference and to speak to you today. My topic is breast metastases in advanced rectal cancer, a case report. I choose the topic not in its complication, but its rarity. So never dismiss any possibility unless you have proof. That's what I've learned from the case. Next, I will explain it from four aspects: background, case description, discussion, and conclusion. Breast cancer is one of the most common types of malignant tumors in women. The global 2020 estimates of cancer incidence indicated that for all these new cases, female breast cancer has passed lung cancer as the most commonly diagnosed cancer, with estimated about 2.26 million for the new cases. And in China, the incidence of breast cancer has also increased every year, ranking fourth in new diagnosed of all cancer cases and the first in women cancers. However, metastases to breast are extremely scarce, mostly from contralateral primary breast cancer. Metastases from extraordinary malignancies to the breast are even more rare, accounting for about 0.2% to 2.7%. So it is difficult to study it in a meaningful manner, or the studies just limited to single center findings. The first reported case of extraordinary breast metastases was in 1903 by Travesik. He published his findings in Lancet, but a century passed, cases and reviews published in the English language of these studies have reported fewer than 500 cases. In 2007, Stephanie conducted a single institution retrospective review of about 169 patients for 15 years. These patients were all pathologically confirmed metastases to the breast for another slight primary tumor site. He wanted to identify their clinical characteristics and assess their clinical outcomes. It is the first largest population study. From his study, these patients' median age was 51 years old. About 88.2% of these patients had prior cancer history, and about 53.9% patients had additional metastatic disease. The most common primary tumor sites were skin and followed by respiratory system. The most common histology was melanoma and followed by adenocarcinoma. And the overall prognosis is very poor. The median survival of these patients is 10 months. Disease status at the time the patient presented with metastases to the breast, whether or not the patient had surgery, and neuroendocrine histology were found to be of prognostic significance. Despite the disease is very rare, metastatic disease to the breast is always important diagnostic concern. The prognosis of the patients with metastases to the breast is very poor, and the median survival is only about 10 to 15 months from the time of diagnosis, and about 70% of these patients have widespread disease when they are diagnosed. So, an accurate and early diagnosis of breast metastases is very important, not just for appropriate treatment, but to prevent these patients from unnecessary treatment. Then I will introduce our case. Our patient was a 49-year-old Chinese woman with history of metastatic rectal cancer. She went to our hospital for the new condition of a painful mass in her left breast in December 2017. Because she had a long time of cancer history, then I will review her treatment process briefly. In 1999, she had undergone radical resection of rectal cancer, which was proven to be moderately differentiated adenocarcinoma. Then she had received 6 cycles of FOLFOX regimen and adjuvant radio irradiation, about 50 degree 25 fractions. In May 2007, she was found bilateral pulmonary, liver, and multiple bone metastases. Then she received treatment in other hospitals, but she could not provide us with his treatment in details. Her condition was stable for a long time until December 2017, her first admit to our hospital for her breast mass. Then, through physical examination, we found several irregular ductile red nodules in the skin around the left nipple, with slightly higher skin temperature, but without the skin deepening and nipple retraction. Upon palpation, we also find a round, well circumscribed and hard mass about 2 centimeters in diameter in the upper outer quadrant of the left breast. In addition, multiple hard nodules were found in her bilateral axilla, and with the disease progression, the nipple appear as cauliflower-like appearance. Then the patient got chest CT. We can see in the CT scan there are an irregular tumor lesion in her left breast, and there are also multiple right lymph node enlargements in her axilla. Then the ultrasound was also showed a hypochondriac tumor lesion of approximately 2 times 2.5 centimeter in the upper outer quadrant, associated with enlarged multiple bilateral axillary lymph nodes. To determine the nature of her nipple and upper outer quadrant mass, we gave him percutaneous ultrasound-guided needle biopsy. Then the breast pathological diagnosis was poorly differentiated adenocarcinoma. Immunohistochemistry showed that the tumor cells were strongly positive for CDX2, Villian, P53, and CA153, but negative for hormone receptors, HER2, CK7, CK20, mammoglobin, GCDFP15. All these results indicated the diagnosis of breast metastases from rectal adenocarcinoma. To review her diagnosis, we asked him to get a gene test, but unfortunately she refused. Then, considering the rapid deterioration of his condition, we gave him targeted treatment with multi-kinase inhibitor, regorafenib, and addition palliative electron beam radiotherapy targeting the left breast metastatic lesions was to prevent her skin ulceration. But unfortunately, it is only 3 months after the metastasis diagnosis, even if we gave him this treatment. Metastatic rectal cancer can spread to any part of a body just like any other cancer. But the most common sites are liver and lungs, and just like the chart shows, metastases to rectal metastases to breast is very rare. So, how can we make the diagnosis? I think one of the most useful data is clinical history. Besides, clinical features are also helpful to make the diagnosis. From the previous literatures, we can see the disease median age was 51 years old, and the common range is about 32 to 87 years. The most common site is left up outer quadrant. It's about 1 to 5 years from the diagnosis of primary tumor to the metastatic breast. The primary clinical signs include single or multiple, round or oval-shaped penis and fast-growing masses, usually without skin dimpling or liporetraction, which is always the presentation of primary breast cancer. And ultrasound usually showed hypertrophic and well-defined masses without calcification, and architecture distortion, and skin changes. In X-ray, we usually see well-defined mass and usually no calcification. But we all know pathological diagnosis is always the gold standard for cancer diagnosis. It's vital and decisive. The pathological diagnosis can be made by ultrasound-guided core needle biopsy or surgical resection. Comparison between primary tumor and breast section by morphological assessment is very helpful to make the diagnosis. But if there is no cancer history, immunohistochemical analysis may be useful in supporting a ranging from extramural site. An immunohistochemical comparison with a non-extramural primary tumor using a pen or antibodies may be useful, and especially in distinction. The combination of CK7 and CK20 is useful in categorizing cancers. Breast cancer is usually CK7 positive and CK20 negative, but on the contrary, colorectal cancer is usually CK7 negative and CK20 positive. GCDFP15 is often expressed by breast cancer, and they can also express in some other cancers, but usually weak and focal. Extrusion markers is also expressed in breast cancer, and they are very useful in the diagnosis. CKCDX2 and Villian is a highly specific marker for gastrointestinal cancers. In general, we should use a group of immunohistochemical markers for differential diagnosis because no marker is 100% specific or sensitive. Although breast metastasis is relatively rare, it may be considered in any patients with history of cancer. For the diagnosis of a suspicious breast mass, the final diagnosis can be confirmed histologically, immunohistochemically, and genetically, especially for differential diagnosis of patients without tumor history. In a word, accurate diagnosis can lead to appropriate treatment. That's all. Thank you.